So I have I've given this talk before, and I plan to give a fair number of webinars in the future. So welcome to this webinar series. This one is one that I've talked about before. I'll try to dive in as deeply as I can. As you can see here, it's talking about, in men, stress urinary incontinence, but I'll talk a bit about women and the difference so that we can be educated. And I'm going to talk about, first of all, and some of the things I do are going to be off the slides here so that I can just give you more of a broad understanding of the topic of incontinence. So follow along with the slides. Sometimes I don't agree with the slides. Sometimes I'm going to contradict the slides, and sometimes I'm going to add to the slides. So let's get started. But what we're mostly here to talk about is what do we do about something called stress urinary incontinence, which I'll define in men primarily. So let's kind of move on here. Let's see if this thing works. There we go. Okay, so that's me, and you've already met me. My main claim to fame is I was kind of in the right place at the right time, and I've done a lot of robotic surgery in my career. I also do a fair amount of other big oncologic cases and reconstructive things. But as of late, I have ventured a lot into what's called prosthetic urology. That means putting things in you to help you. That mostly refers to things like fixing incontinence and also erectile dysfunction, which I gave a talk about a little in the past, and I'll give a talk about moving forward. And if you missed my last talk, I gave it last week on enlarged prostate, or BPH. So we'll dive in and talk about male stress incontinence. I'm actually gonna, so that we're not just looking at that slide, let me talk about incontinence in general, okay? So we're gonna talk about stress incontinence, and then we're going to talk about male stress incontinence. So we're kind of going down a flow chart of topics in the world of incontinence. But let's talk about the other forms of incontinence so everybody understands that there's a difference. Probably the most common other form of incontinence other than stress incontinence, which I'll get to last because that's what the talk is on, is called urge incontinence. So urge incontinence. And so if someone comes in, incontinence is you're leaking urine. That's the bottom line. And we're going to get a sense as to how much you're leaking based on how many pads or incontinence garments that you wear. What do you do about that incontinence? So that's what incontinence is in my world as a urologist. But just as common, or even more common than stress incontinence, is something called urge incontinence. So what's that? Urge incontinence is just sort of what it sounds like. You have to urgently go to the bathroom. You have to suddenly go to the bathroom. Oh my God, I have to get to the bathroom. And if someone's in the line or someone's at the door, all of a sudden the door's locked. Oh my God. And you may actually have an accident on yourself. And sometimes it's the whole bladder. Sometimes it's a little, but it's a big problem for people. It starts with something called overactive bladder, and then urge incontinence is the extreme form of overactive bladder. What causes it? Usually we don't know. So that's number one. Age. People just have overactive bladder, more common in men than women. I'm sorry, more common in women than men. People that have had radiation to the area will have that problem. People that have had things like Parkinson's, Alzheimer's, multiple sclerosis, things where the brain has something affecting it so that it's a little bit disconnected from giving the bladder the proper permission to urinate. That's urge incontinence. And that is absolutely as bad as stress incontinence, but it's different solutions. It's usually medicine, and then if medicine doesn't work, oftentimes we might offer things like Botox injections, or we might offer, and certainly in this practice, we offer like an implanted nerve stimulator device that works really well. So we're doing that now, but that's for urge incontinence. Next form of incontinence that I see all the time, I see more men than women in my practice, is called overflow incontinence. What's overflow incontinence? That is basically from what I talked about last week, enlarged prostate, to the most severe degree. Your bladder can't empty, it's very full, and it's just spilling out. As more urine comes in, urine spills out. That's overflow incontinence. The treatment for that is an operation for enlarged prostate. So that's the treatment for overflow incontinence. Not going to talk about that today. Very much talked about that before. It's on my website at dcurology.net and my YouTube channel. Then there's going to be something you're going to talk, there's a slide here that's going to talk about stress incontinence, and it's going to talk about the most common form of it, which is positional. You stand up, you sit down, you cough, you sneeze, you pass gas. Women have the same problem. That's called stress incontinence. They have it for different reasons. But you can also have the worst degree of that, which is called total incontinence. Total incontinence is where you just leak all of your urine. It's debilitating. It's terrible. And so I'm going to add that to the list of the things that we're going to talk about tonight, because we're going to talk about how we fix things like that. So now you know there's a lot of different forms of incontinence. And now let's move in on stress incontinence. Let's define it first. What is stress incontinence? It doesn't mean you're anxious or stressed. It means you're bearing down, you're increasing your abdominal pressure, and for that reason, it's pushing on your bladder. I always call it like a pastry bag. It's pushing the frosting out of a pastry bag. The frosting's urine. Women get stress incontinence. There's not a slide on this, but let's talk about it a bit. Women generally get stress incontinence just because of the fact that the way they are continent, and we're going to talk about how a man is continent later. So I'm giving you all the background now. A woman has stress incontinence largely because the way they are continent is their bladder sits on the top wall of their vagina. And so the vagina holds their bladder, and when they cough, it pushes against the vagina and it closes. So if there's something there like childbirth, anything like that, or just aging that causes that wall of the vagina to sag a bit, it's not going to support the bladder, and that's why they get stress incontinence. It's a very different problem, and it's caused by a different problem, different solutions than male stress incontinence. So that's the background. Let's dive into male stress incontinence. So what is it? We've already talked about it, and it generally refers to not you're stressed out, but when you stress the bladder, when you do things that raise your intra-abdominal pressure. So it's lifting, bending, laughing, but it's bearing down. It's very common, which we'll talk about. It's very common, but it's very, very undertreated. That's one of the reasons we try to do this education, so that people understand, maybe tell their friends. If you go down a supermarket, you're going to see how many pads are sold there, and you're going to realize that there's an easy fix for that problem. So you might understand that most of the people buying those pads don't necessarily know what the fixes are. So here's an anatomy slide of the male anatomy, obviously. So let's talk about how a man is continent. And I think I'm going to worry less a little bit about the words here, because it's not how I necessarily explain it to patients. And patients that are on here that have had a prostatectomy with me, they've heard me somewhat explain how is a person continent, how a person is continent, how a man is continent, and how a woman is continent, meaning they hold urine, is not this muscle, the sphincter. Most of these slides are talking about this muscle, the sphincter. We'll get to that. How most people are continent is that the bladder, which holds your urine, puckers down here at the bottom. So it squeezes down here. You have no control over that. Your spinal cord controls that. It puckers just like an anus. We don't think about squeezing our anus all the time. We don't think about squeezing our bladder. But that's how we're dry. That's how a woman's dry. That's how a man is dry. Now, and we talked, but the problem is, in a woman, at least, when you cough or sneeze really hard, it's not super closed, so it needs something else to close it. We've talked about that. In a man, what there is there's a little bit of obstruction to flow at the prostate. And then there's the sphincter muscle. And what's that? That's what we all know. If you need to stop urinating all of a sudden, you squeeze it. You can feel it inside when you squeeze it. Kind of the same muscle you would use to squeeze your anus. But that's not what keeps us dry. That's only what kind of adds to it. That's like a downstream helper to things. We'll come back to that. Okay. So we call in our field the bladder neck here the internal sphincter, and the one that you can control, the external sphincter. But it's the internal sphincter in a man, which is where all the action is primarily. Now, what causes trouble? Actually, if we go back to this, we can talk about this, and it'll explain some of the subsequent slides. So what causes a man to be incontinent? Well, number one reason is me, people like me, people that are doing surgery on you, people that are fooling with your bladder neck. So a prostatectomy fools with your bladder neck. And so a prostatectomy is the removal of this and then the connection of this to this. There's a slide later. But when the bladder neck senses that something's not right, it simply won't contract. And that's what a man's waiting for after a prostatectomy. He's waiting for that to contract. That's in a man. If you have injury to this sphincter, which is the voluntary sphincter, usually that alone won't cause you to be incontinent. So prostate cancer surgery is going to generally cause incontinence at this level, the bladder neck. Think BPH surgery or enlarged prostate surgery, classically called a TURP or a roto-rooter job, that might cause injury to this sphincter, but it also causes injury here. If this is perfect, this is not what keeps you dry, but injury to both of them is what's going to cause a problem for you. And there's different reasons, but the number one reason, again, tends to be treatment of things by urologists. The number two, you might have problems with your sphincter here. If you have a spinal cord injury, there's a spinal cord problem. Same thing with here, but those are much more rare. We're not going to talk about them tonight. We talked about, therefore, that big culprit here is prostate cancer surgery. I have to show you all of these references later. This time I actually looked up who said this, like who said only 50% of men leak after a prostatectomy. Anyone who's had a prostatectomy with me knows I say 100% of people leak. I noticed that this reference is, for instance, from 1999. It was a very different world back then. We reported things differently. So I would say that everyone leaks after a prostatectomy. In my hands, about 5 to 10%, 5 to 7% are going to have incontinence to some degree 1 year after treatment. So you're going to find these numbers all over the place. Important to know, and now you do know because we've talked about it, that there are lots of other causes of incontinence, and they're not all the type that we're going to call stress incontinence. But we've talked about neurologic disorders. Radiation typically causes problems at the bladder neck because it holds it open. It makes it scarred and stays open. It won't close. It won't pucker. And we've talked about that roto-rooter job problem of enlarged prostate surgery. We didn't talk too much about pelvic trauma, but that can tear apart all these things and cause trouble too. Anyone that has incontinence really doesn't need to see this slide, so I'm going to kind of skip through it. Let's just, I left it in here just to be able to say that I do a lot of, I've done a lot of surgery in my career, and I think I've had a lot of gratifying moments, and I've had some sad moments, and not everybody can do well with those big surgeries that we do. But probably one of the most gratifying things that I do, actually, I think, is taking someone that really didn't realize that they could be fixed with their incontinence. They've been wearing diapers for the past 7 years, and that's about the average amount of time it takes for someone who hasn't been told about these procedures to get it fixed, and then to see how happy they are when they are fixed. It's a true game changer. It is a very gratifying moment in my field, and it's one of the reasons I gravitated to doing these cases, and that's basically what we'll say about that slide. So we know it's a big problem. We know it's an undertreated problem. I try for it to be very upfront about the problem with patients that I'm going to affect, because I'm going to want to fix this. I don't want anyone to continue to have this problem. And if they have this problem, if it's right after a enlarged prostate procedure and I can see there's a sphincter damage, that's a very rare issue. I'm usually seeing that if someone comes to me for that. That's someone that is not going to get better. So I'll offer to fix that right away. Worth pointing out that I'm not going to offer to fix someone after a prostatectomy for 9 to 12 months, because it can still resolve on its own at that point. And then the one other thing I wanted to add, and I was going to point it out in a different slide, is that it doesn't matter how much you're leaking to decide that you want it to be fixed. And I think that's one thing that I really buy into that some others don't. If a person came in to see me and they said, I'm still wearing a pad a day, and I said, that's great, good for you, that's no big deal, then it's something that the patient accepts and they live with. I tend to view it as, if it makes you unhappy in any way, I fixed people that didn't even wear pads. They just didn't like how they leaked a bit when they were sexually active. That can be a problem. They didn't like the fact that they're runners and they leak a bit when they run, but they don't leak at other times. If it makes you unhappy, it's something you should seek treatment for. So that's what we're here to talk about. We've pretty much already talked about this. And again, some of these slides are old, et cetera, but taking out the prostate is something that has the potential of hurting both of those sphincters we discussed with. Downstream is the voluntary muscle. In the era of robotic surgery, we usually don't injure that anymore. We did that when we used to make an incision. And then no matter how gentle I am, no matter how good I am, no matter how much I try to just absolutely gently tease the prostate away from the bladder, neck, as you see depicted here. At the end of the day, the bladder, I always say it's like a slug walking across a sidewalk. If you touch its tentacles, it knows you're there. It's not moving. It's not going to do anything until it thinks that the coast is clear. And it's not clear right after a prostatectomy. But, I just talked to a patient. He was a younger patient. He had a prostatectomy, and he really never really had much incontinence. There's plenty of people like that. And on the flip side, there's people that have a lot. It tends to correlate in large part, not so much with your age, this is how I view it, but more so with your degree of bladder dysfunction as you get older from having an enlarged prostate. That it tends to dictate how much you leak after surgery. But that's a talk for another day. Just recognize it happens after surgery. It's a big problem. Many prostatectomies done. And I really feel, it's more important to talk to patients about things like their erections and their incontinence than even the surgery, to be honest with you, when we're talking about surgery. That's the part I'm really going to go to town for a patient about. It's all about getting your life back and being back pretty much how you were before. So what do people do when they leak? Well, in my hands, we're going to wait until a year, and then most of my patients are going to ask to be fixed, because I don't push people to do anything, but I also don't sweep things under the rug. I view it as there's no reason to get used to wearing pads. Pads are really good these days, but there's not a good reason to just live with it and get used to it. Most people, it's a fear of the unknown. They already have had a surgery. They don't really want to go through another one necessarily. And I always say you can get used to anything in life. Someone in Afghanistan can have their arm blown off. They're going to get used to that because they have to get used to that. You don't have to get used to incontinence. But a lot of the things that are on this list are along the lines of just getting used to it. Saying I'm not going to drink any fluid, that's not a good long-term plan. Saying I'm going to urinate constantly every hour because I'm going to keep my bladder empty, that a lot of people do that, but it's not a great long-term plan. It controls your life. A word here about these things. I do sometimes send patients to a physical therapy, but the purpose of going to physical therapy, in my opinion, is for those patients, and it's probably 20% of them in my office, that they just don't seem to grasp the concept of squeezing their external sphincter. They're either overthinking it, or they just never had to think about it before. I'll say, how do you stop urinating when the phone rings or if someone knocks at your door? And they'll just say, I don't know, it just happens. And that's a bad answer, because it's not I don't know, it's you're volitionally squeezing a muscle. Well, sometimes we need a physical therapist to teach you what that muscle is. Kegel exercises are something I don't really think helps a person, but I very much teach the act of a Kegel applied to one's life. But the notion of doing it 20 times in a row, that helps women because they're trying to take their vagina to the gym and bulk up things so that they have that backboard. If it's a bladder neck issue, I don't find doing that 20 times helps at all. But I do think doing it when you're going to leak helps you leak less and helps you get out of that last pad. So I taught 2 people today how to do that, but it's not to do them as exercises. And then biofeedback, again, is really just a tool that physical therapists might use. So at 3 months, if I see a person's leaking and they just have no idea what their pelvic floor muscles are, I will send them there because my words aren't getting through. And then lastly, this is what most people do. I'm a strong opponent to the concept of giving up and putting on a condom catheter. There'd be no reason for someone that was young enough to have a procedure to do that. A penile clamp, likewise, once you start doing a penile clamp, you'll never squeeze your own sphincter. You'll never work on helping yourself. And so these things, in my opinion, I'm throwing in the towel entirely. Would make much more sense to get that fixed, in my opinion. Diapers and pads are certainly what everyone has to do, and they're good these days. They're very absorbent. Again, my own philosophy is, do some soul searching and think, do you really want to wear that pad forever? Because you don't have to. This is just a slide that says the obvious, which is pads are expensive. But pads are pads. You don't want to wear pads. So now these last few slides, and the people helping me with this talk, they're the company that make these 2 devices that I'm about to describe. So that's why the talk is a little bit limited to these products. But these are fantastic products. These are very high-tech products. I've actually seen how they're made. And there's a high degree of engineering that goes into them. The first thing, and there are other companies, but they really don't enter the market to the degree that that this company does, which is called Boston Scientific. So the first device, it's not really a device, it's just something that we implant and we do. We call that a male sling. That had been the way you fix female incontinence. It still is done. You might remember all of these commercials some time ago about pelvic mesh, which really didn't even have to do with the slings that were helping all those women. But because of all those lawsuits that were kind of pulled other things in, you don't see as much sling surgery in women. It's starting to come back now. But none of that had anything to do with the man in terms of the things that the lawsuits were about. That's important to point out. So what is a male sling? I'll show kind of a procedure, but what's important to understand is that a male sling, you have to pick the patient properly. And if you pick the patient properly, it's almost 100% success in my practice. But that's because I only offer it to those people that only leak 1 or 2 pads a day. So if a person says, I'm soaking 3 pads like the baby, like the young boy in this picture, that's not going to get you out of pads. My own philosophy is not to make it better. It's to get you out of pads. It's up to the patient, of course, but that's usually how I view it. If you have 1 or 2 pads per day and you have not had radiation, that's important. It really doesn't work if you've been radiated. I've tried it. They always say it. You can do it. It's not going to get you out of pads. So I don't offer this to radiated folks anymore. But it is a very simple procedure. It's an outpatient procedure. It could even be done in a surgery center, and you're dry immediately. There's no buttons to press. There's nothing for you to do. You're just dry. You've gotten your problem and you fixed it. You have a small incision under your scrotum, a couple little needle punctures, and you're fixed. This is if a person's only leaking a pad or 2 a day and they're at all bothered, I'm going to offer this, and if they honor me by doing it, it's almost a home run every time. There's always complications to what we do, but there's very few with this. This is not the average person. I don't know is going to necessarily know what this is, but this is your pelvic bone, and it's got a big hole in it. So we basically guide this sling material down through your inner thigh, under an incision under your scrotum, and back up. And it just basically, I call it, because I say the bladder neck needs to pucker, and those that leak are not quite puckered enough. What happens is this pulls the bottom of the urethra up into the bladder, and it just creates an excellent pucker. I usually take a before and after picture. And it's for someone that needs a little more of their bladder neck puckered, and it works fantastically. Again, it's got to be for the right person, but if you're the right person and this is offered to you, this is an excellent, excellent thing to do. I've seen in my practice in terms of complications, that's the next thing. In terms of complications, I've had one patient where they couldn't urinate freely afterwards, had to do a small procedure to release it. Still, basically, it worked. Still doesn't regret the decision. Every now and then, a person can't urinate freely afterwards, and that's just because they've been leaking and their bladder has not had any resistance to flow. So overnight, it has a little resistance. The bladder gets stronger, just like a person that does curls at the gym. And actually now, if I see a person can't urinate at first, that's actually 100% success rate. So I actually take that as a positive thing, not a negative thing. So not a lot of complications with this procedure. Way to go if you're not leaking much and you haven't had radiation. If you've had radiation or you're leaking more, or even if you have that total incontinence that we've talked about, not for the urge incontinence, not for the overflow incontinence, but it's for all degrees of incontinence, from terrible to just a little more than uncomfortable offering a sling. The treatment is called an artificial sphincter. Artificial sphincter. And if you can remember my drawing, okay, you can tell we're in downtown DC because you're hearing some sirens here. So if you can remember my drawing, there is the voluntary external sphincter, and then there's the internal sphincter. I view this as which is the bladder neck. I view this as a substitute for the internal sphincter, meaning the always-on sphincter only opens when you're urinating, then closes automatically. We're just going to place it downstream, even more downstream from the voluntary one that you would use. And that's what it is. So I like it to be called the artificial internal urinary sphincter. Okay. Now, this is more of an implanted device. There is a button to push. I'll show you a schematic. And sometimes people have hesitation to this because they're saying, oh, you're implanting this thing in me, but no one sees it. No one knows you have it. You don't see anything. It's entirely internal. You go and pee at a urinal. Nobody knows. It's just part of your, pre-urination routine. You press a little pump one time, it opens, and you urinate just like anyone else. No one would have any idea that you had this thing in. And patients never mention it to me long term. It just becomes part of them. They don't even think about it. Never had anyone lament, oh, but I have this thing that I can feel in my scrotum and I don't like it and it makes me feel weird. I've never heard anyone say that. So this is a schematic as to what is an artificial sphincter. So it's a small little pump. It's in your scrotum. You don't see it. It's under the skin. We're in essence putting a blood pressure cuff around the urethra. Remember, this is where the internal sphincter would be. This is where the external sphincter would be if there was a prostate. And it's downstream here. What it is, instead of it inflating with air, it inflates with water. The water comes from a balloon that we tuck under your pubic bone. You won't have any clue that it's there. The only thing that you're going to know is there really is this pump here. This would be on the left side. This would be for a left-handed patient. We usually put it on the right side so that you can just reach down and do that. But again, I think the next slide is maybe a video. Yeah, so let's play the video, and maybe it kind of explains a little bit more of how it works and what it is, and I'll try to give you a bit of a play-by-play. I think this is on my website as well. By the way, all this stuff that I'm talking about is on my website at dcurology.net. So if one had a sphincter in place, these are the things we discussed. I need to urinate. I press it once, maybe twice. No one knows. It's going to pump the water out of this cuff. There's a video on my website of it actually showing you that it opens, stays open for about 45 seconds, and then it closes on itself. So you don't have to do anything to close it. It's one pump. You urinate like everybody else, and then you just do your business, put it back in your pants, and hopefully wash your hands. So it's that simple. That's a sphincter. And again, that's what you need. I mean, it's always a shame to me when I see somebody after, they've been living with it, leaking 6 pads a day, 7 pads a day, and maybe they went off to a place to have a prostatectomy and then didn't get their post-operative care there, and they may not know about it. So I want you all to know. So this is about a sphincter. It also is an outpatient procedure. It has a little incision, again, even a smaller incision than the sling under your scrotum. Sometimes there's a second incision. Sometimes there isn't, to put that little balloon in place. Important to note, the sling, you're immediately continent, but the sphincter, because of the fact that we are ultra paranoid. I talked to a patient today that has one. Every time he calls me about anything he has, he knows he needs to call me right away. And I have to think, is his sphincter okay? Is his cuff okay? Does he have something called an erosion? The risks with a sphincter are a little higher than with a sling. And the risks are infection and erosion. Infection and erosion. Now, all my patients that have had a sphincter know those terms, infection and erosion. We don't want either one to happen. The infection usually occurs because of an erosion. What's an erosion? Where the cuff is around your urethra, and all the erosions I've thus far seen have been in patients that have had radiation. Radiation can really affect the blood flow down there, but it's where the tissue sort of breaks down. It just doesn't like having it there. When that happens, we have no choice but to sort of remove everything and come back later, which we certainly can do, and fix everything. But it's important because we don't want something squeezing on where I just dissected the urethra. We leave the thing open for 4 to 6 weeks. We let it heal, and then we turn it on. And that's that visit that I was talking about that's so gratifying, the day a man activates his sphincter, because that we know that person has had severe incontinence, or I wouldn't have offered the sphincter. And that is definitely a game changer in that man's life the day we activate the sphincter. Activating is just pressing that pump in the scrotum, and then they're on their own, and then they move on to their life and they're happy. This is just pointing out that, again, and it's what I see also, very few patients lament having a sphincter. Patients will struggle with the decision to do it for a long time. Once they've done it, it's interesting that once they've done it and they've tasted what being dry is like, they may have waited 7 years, 8 years to do it because they were scared to do it. And then the minute there's an issue, and there can be issues with them, sometimes there's a leak of, fluid leaches out and we have to replace it. Sometimes the urethra shrinks a little bit. Sometimes, we have to fix something. The minute it doesn't work, they're back saying, okay, take me back and fix that. Because once they taste what life is like not leaking, they never are willing to go back. That's my experience. Now, I do give a talk on erections. In this same company, we talk about penile prostheses. They are not always covered by Medicare. I've never seen a situation really where this is not covered, for instance. So this is cost shouldn't really be a concern. This is very much a covered procedure. There might be exceptions, but I haven't seen it yet. And again, I guess these are just the take-home points. And my take-home points are just, it's easier than you think. People will say, I'm worried, what if something bad happens, etc. I always say, it really is the old, our host coaches his son's baseball team. I coached my son's baseball team. I always used to say, if you don't take a swing, you're guaranteed not to get a hit. Swing and swing like you want to get a home run, and maybe you will. So we seek home runs in this world. And I'm assuming this to be sort of a disclaimer slide. Here's the issues. Here are the issues that can happen. Let's see. Yeah, male sling cannot work. Again, I've largely found that to be an issue of not choosing the right patient. Notice you don't see a lot of words about infection and erosion here. I really haven't had a lot of these irritations, etc. So I think we've covered that. And with the sphincter, there's the word infection. There's the word erosion. And there's a lifetime of these things. There is a life expectancy of the devices. I think they usually quote 7 years or so, something like that. That's probably about right where we may have to fix it. But actually going to fix it's a lot easier than replace it. And again, everyone always asks to do that. The company has this site, fixincontinence.com, so you can sort of go there. I, of course, think it's better to go to my website, which is dcurology.net, and you're going to find a lot of things that are there. A bit more of the world according to me there, but you'll find the videos and instructions, and this is what we do, etc. And then these are the references. Again, I was looking at some of these references, and some of them are pretty old. So this is where I don't always agree with them, but these are they. And then we'll just shift down to the bottom here. And that's me. So we're going to try to answer as many questions as we can. I love answering questions, and I love talking.